The history of development of IVF in India is very interesting, unique, and ran parallel with a lot of events that were happening in the academic circles of England approximately 4 decades ago.
The centers where the pioneering work of IVF was done in India were mostly located in the metro cities of Mumbai, Kolkata, and Bengaluru.
Our guest for tonight is a special one. Somebody who is responsible for the second test tube baby in India and in Mumbai, going toe-to-toe with what was happening in the United Kingdom at that time. It was a unique occurrence, and therefore, she deserves special mention both in our minds and in the thought processes.
She was and always has been a diligent student of science with a great grounding and a great scientific temperament. She went abroad, picked up the nuances of IVF science, and came back here and executed them successfully in a private setup.
A person who took pride in teaching the nuances of reproductive molecular biology to a team along with the values that she imparted to them. Here was a person who actually built a team from ground upwards. An emeritus professor of the Bombay Hospital Institute of Medical Sciences, a physician to the Governor of Maharashtra, a physician to the Armed Forces Medical Services, a person who literally embodies what is called as education given to the higher institutions, a past president of FOGSI, ISAR, a person dedicated, one-dimensional, but complete in what she did.
And she's also been a shining beacon of light and inspiration to many of the babies who were born through IVF with her.
We feel privileged and honored to welcome Dr. Sadhana Desai, the doyen of IVF fraternity in India, to our first podcast, the Gufic's Hall of Fame, the life and the times of IVF masters. I'm your host, Dr. Kaustubh Kulkarni, and my co-host and wife, Dr. Sharda Kulkarni. Welcome to the podcast. Madam, it's a pleasure, first of all, to have you with us, conversing in Gufic's get-together for legends like you. It's a learning experience. I would like to ask you a question. I read somewhere that you mentioned the parents have such a big role. Your parents, for example, your mother you mentioned, had a big role in telling you that you should not only inculcate good habits like being spendthrift, being very honest with your work, seeing that you're truthful most times, and all the other things that go with it. Now, apparently, you mentioned that she had a big role to say you should become a big doctor. And though there was a legal background to the entire family, we know about your father and his stature in the legal world. That decision your parents took at that point, you mentioned at that young age. But from the routine OB/GYN that you had gone into and you had studied abroad to first come back to India and to take up infertility, how did the whole process happen?
No, it so happened that when I was a registrar in gynaecology at Sion Hospital,
Yes.
I used to come across a lot of infertile patients who were very keen to have a baby, and they would come week after week, sit in the OPDs, and they would very anxiously look at us that we will do some miracles and they will become pregnant.
True.
Unfortunately, at that time, infertility was not a subject of its own.
Yes, I remember.
And there was not much advances in the treatment of infertile patients also. Even in UK and US, infertility was coming up as a separate subject in its beginning. They were also struggling. Only teaching hospitals had these infertility departments.
Right.
So when I decided that when I'll go to UK for doing my MRCOG, I should learn more about managing infertility patients.
I see.
And that is what made me decide to go for fertility, because I got an opportunity when I was in UK to learn infertility. So when I came back knowing a better understanding of the managing infertile patients, and that is how I started my infertility practice.
You were always sure you wanted to come back to India?
Yes, I always wanted to come back to India. I never wanted to settle because I was used to a little happy life in India. And usually when you are abroad, you have to work very hard.
Yes.
You have to manage everything.
Right.
Here everything is given in platter, food and all, servants and all that luxury. That was not going to be there. So
True.
I wanted to come back.
It would have been such a loss to the IVF industry here in India if you hadn't.
That is all a luck factor. See, this is destiny. Nobody can predict what is your future. You do whatever you think is best at that moment.
Right.
So at that moment, I wanted to learn infertility and I wanted to come back and settle. That is what I wanted to come back. And I was interested in teaching. So I also wanted an appointment in teaching hospital.
Right. That is very important.
And I was not sure whether my infertility practice alone will do. So I didn't want to give up my obstetric and gynec.
Right.
So infertility was part of, I had 2 hours a day only for fertility. So I had a partner who was a very good friend of mine, Dr. Hansotia.
Yes, Madam Hansotia.
And together we would to spend 2 hours only for fertility practice. So that all patients interested in having a baby were called only during that time.
Right, right.
So let's say you departmentalized and looked at infertility as a subject which should be dealt not just by the people who take exams, but even by you when you
Correct. See, that time the monitoring of ovulation did not exist. Ultrasonography was not there.
True.
So I had brought these stains to do vaginal cytology.
Yes, yes.
And we used to take out cervical mucus. I had brought some temperatures, thermometers for finding it out ovulation. So we used to determine ovulation by basal body temperature chart, by cervical mucus, by vaginal cytology, and find out when the patients have ovulated.
It's amazing to imagine that in today's
Correct, no?
day.
So it was the infertility treatment was at its basics.
Yes.
When we started.
Compared to where we are today,
Correct,
that seemed like a different world.
correct.
Madam, you went to Melbourne,
Yes.
since that was one of the chief centers and they were quite advanced in their IVF treatments that they offered. And when you went there and you saw the whole laboratory setup, especially that is required, did you find it very challenging to come back and to replicate that whole setup here?
You see, let me tell you very honestly, it was almost, I was in 10 years of my fertility practice when I went to Melbourne.
Okay.
So my patients would always keep on telling, doctor, why don't you start the IVF here? We are in no position to go abroad and take treatment. If you start, it will be nice. But I was doubting whether I'll be able to start because I was always under impression that it requires a very strict culture laboratory with a very highly sophisticated laboratory and animal house for doing the animal experiments, because that time all the media was prepared in-house. Right. It was not commercially available. So we had to prepare the media and then test whether that media was working or not on the mouse embryo.
Yes.
So you had to have this breeding mice and laboratory for animal laboratory had to be here. So I was not sure whether I'll be able to do it or not. So we decided, myself and Dr. Hansotia, let's go and do one course in Melbourne, because in UK, Strepto and Edwards were not encouraging any outsiders to learn IVF. It was only in Australia
That's
that they were
amazing
offering.
to think
Yes.
of now.
Yeah, so they were very secretive. They were not offering courses. But Melbourne people were very nice and they were offering. So we said, "Okay, let's join the course." So for 3 weeks we went. And when they taught us everything, how to dissect mice embryo, how to look at the embryo, how the egg looks like under the microscope, how to fertilize. They used to have classes. So Dr. Hansotia and myself, we used to both with a paper and pencil write down all whatever they would say in and there. And after the lectures were over at night, we would read out what we have written and we would memorize what was told to us. And we found it was not so difficult. That laboratory of theirs was not that highly sophisticated laboratory that we thought we could not replicate. The question was only to get the mice embryos. That was the problem.
Since you were in a private setup,
Yes.
having access to an animal laboratory
It was impossible. You have to have a
difficult.
big setup.
Correct.
And government hospitals were not encouraging infertility treatment
At
anyway.
all,
That was
yes.
not their priority.
Right.
So we had to set up. So then we said, let's, breed the embryos, the mice in our own garage and do it.
Madam, you actually set up a laboratory and animal house in the garage at a point today we can't imagine.
Arey, but you won't believe that time petrol smell, the cars were also not so sophisticated. And so many times the mice would not breed because of that smell of the petrol.
So your progress in the field depended on how fertile the mice were as well as how well they would multiply.
So we had gone through tough time to start the IVF, but we managed it.
Madam, I have a question. Let us say that we understand you're teething trouble with infrastructure. I have a question. Say, as a team leader, you chose people for a team and you realized it very early in life that you had to make it either as a team or it wouldn't work. And sonography was coming into its own at that point of time. Same thing with your radioimmunoassays, which were helping us. How does a team leader, as in say you or the new generation, choose?
No, it was very different circumstances at that time. I chose Amrish Dalal because I knew his father and he had a radiology center right across my consulting room. So he had introduced his son to me and saying, "This is my son Amrish Dalal. He has brought this ultrasound machine and if you have any patients, he is happy to help you." So I said, "If you are happy to help me, let's start doing ovulation study. So I will do cervical mucus
And you will
temperature chart and you will do the sonography and you will tell me when the patient ovulates and I will see whether it collaborates with my findings."
Fantastic.
So you didn't need Google Maps to tell the patient where to go for sonography.
No, they had to just go across. And I said, "You will not charge them." He said, "Okay." If you are interested to set up with me, I am doing this. As I may succeed, I may not succeed. But if you are interested, you do few cases. So we decided we'll do 15 cases free.
I see.
For ovulation, for all those patients.
And the patients didn't have a choice at that point of time.
Patients were coming to us and so we said this is a new technology to make it more accurate. So, and they were not going to spend anything from their pockets. So
that was, I think, the main way it worked. Plus, I think, Madam, to convince a group of people to work with you literally free of cost.
Yeah, but because they were interested.
Yes.
See, you have to choose somebody who is interested, somebody who is only thinking of how to make money out of the patient. You can't take them.
IVF is such a great team effort. There is sonography, there is embryology, there is a clinical aspect. And I incidentally happened to pick up embryology way back when we were setting up. And I found it much more interesting and I thought I had a ken for it, like he had a ken for the clinical side. What, according to you, Madam, are the qualities or what kind of an aptitude should an embryologist have to really make good progress in this field?
I think it's a new branch and there is lot of scope. So nowadays those students who are doing life sciences
Yes, absolutely.
and they know a little bit about the human reproduction, they are the right people to become embryologist, because you must have a basic knowledge. You can't be, the BSc in some subject which has nothing to do with life science.
True.
So this is number one. Number two, they should have a in-depth knowledge of human reproduction. So they have to learn more how the egg looks under the microscope, how a mature egg should look under the microscope, how do you grade the embryos, how do you cultivate, what are the basic requirements for the growth of the embryo. So it is a subject by itself, and the person has to be interested. If they have taken life sciences, I think there is a good scope to become an embryologist. This is what I personally think. So they have to be sincere and honest. The problem with the embryologist is sometimes because they are associated with the clinician, sometimes clinician dominate over the embryologist.
Oh yes,
And that is where sometimes things go wrong, because if the clinician says this I think is better, embryologist is not able to say no, you are wrong and I am right, So sometimes there is a clash of the ego. That is what happens. But if you give free hand to the embryologist, they will do a good job.
Yes. A healthy environment where there is a good give-take of ideas between the clinician and embryologist.
So in the beginning,
is required.
I had to teach the embryologist what is to be done, because whatever we had learned, we would said. But then we started taking initially we were asking from the Institute of Research in Reproduction, people working there.
Yes.
We picked up the embryologists from their institute, so who knew little bit about what was happening.
Wasn't it an advantage, madam, to be in a city like Mumbai,
of course,
where all these facilities, sometimes all we had to do was, put your hands around and get. I wanted to ask you, to a point where you set up your lab, you had gone through practice to Melbourne to pick up all the rudiments, and then, as you said, trained even the embryologist to take care. In its infancy, and with something which you thought was not 100% perfect at that point of time, you do your first IVF on a person, and on sonography, you see a heartbeat. Can you describe that? Because,
Okay, that is the moment I don't think I'll forget. I'll tell you a small story behind it. This patient who became pregnant, my first IVF pregnancy, this woman was a case of genital COX.
Oh, I see.
Yeah, and about a couple of years ago, before even I started IVF, she had come to me because I was doing infertility practice.
Yes.
And I had done her laparoscopy and told her that her tubes are irreparably blocked and she should adopt a child. So when she heard that I have started doing IVF, she came back to me and said, Doctor, I belong to a very conservative Marwadi family.
I see.
They don't believe in adopting. But now that you have started doing IVF, why don't you do IVF on me? So then I told her, look, I am just beginning. I haven't got any success. I am just trying on the patients. So if you are willing to be, I will try and not harm you. I will not do anything that will harm your health. Right. But if you are willing, I will take you on my program. So she was one of those 13 or 14 patients which I had collected.
The first
group to do it. So when I did an IVF and transferred the embryo, she came after 2-3 weeks and told me, Doctor, my pregnancy test is negative.
Oh my God.
Oh.
And I haven't got my period. So I got very worried. I said, I hope that TB has not come back again. So I said, why don't you go and do sonography to find out? So she saw that worry on my face And she told me, doctor, don't worry if it is negative. You can try again on me.
So she was the one who made you feel
He
comfortable.
felt comfortable. I said, okay, that's fine, but let us find out why you haven't got a period with a negative pregnancy test.
Yes.
So I sent her to Dr. Amrish Dalal to see why she not got
Oh, I see.
negative.
So nobody expected a
beta
pregnancy.
HCG. It was not urine pregnancy test. It was beta HCG which was negative.
I see.
So
It was a
Amrish telephoned and told me, come running. We'll see
was across the
baby's
street.
heartbeats of your first IVF pregnancy.
Oh my
Oh
God.
my God.
So I really jumped and went, and I saw that heart beating. I was so thrilled, and the patient was crying
Oh my
with pleasure, you know. It
And
was
I'm
a
sure
very good
everybody
one.
must have cried.
Yeah, so then I telephoned to Dr. Sushil Shah and told him,
Your
look,
test is not up to the... So it is...
your beta HCG is all rubbish. Come and see the baby's heartbeat. Our first baby of IVF is going to be, you know, now there is going to be a result.
But it's amazing that the first experience itself teaches you that you should never get disheartened, and like the patient told you.
Correct. The patient, I got worried not because she was not pregnant, because I was not getting any pregnancy. I
Clearly.
said, maybe, you know,
Yes.
she is also one of those. Big surprise.
Even today, madam, but with IVF, we still don't have anywhere near 100% results. We still have maybe a maximum of 60 to 70% that we're achieving with even with frozen embryo transfer, cumulative pregnancy rate. At that time, of course, the failure rate was much higher.
Yeah, 15 to 25% was the success rate.
Yes. So how did you shore up the confidence of your team and keep them motivated then?
Okay, what I used to do, and I used to do it for many, many years, that every week we would have 1 hour meeting with embryologists, ourselves, and the nurse in charge. And we would take every case and discuss why how many eggs we got, how many got fertilized, what was the problem, why she didn't become pregnant.
Right.
And then we would discuss where we should improve.
Okay.
So that is how we used to sit and discuss. So not blame each other,
Right.
but discuss.
It was like an audit, madam. That's what you meant.
Yeah. So that is what we would sit and discuss. And whenever I would go to attend conference abroad, I would take my embryologist with me.
Oh, that's very
Okay.
interesting.
Yes. Because I thought if embryologist doesn't perform well, whatever I do, not going to give me result.
Madam, we would know in my setup if there wasn't a result. The thing that would suffer would be the quality of food sometimes, or the temper in the house for the next 2 days till we got the next
But
pregnancy.
your problem is different. My embryologist would listen to me. Here you have to listen to your embryologist.
Oh, yes. Automatically, Sharda gravitated towards her field where she could dominate, and I'm happy for it because all the results coming there. But
Correct.
I think, madam, one thing you forgot to mention was the requirement of an embryologist. The wife technically should be an embryologist, and the husband should be the clinician, so you know who's the boss, as they say in the house.
But see, whatever you say, I have yet to see wife becoming an clinician and husband being an embryologist.
Yes, that is rare. I haven't seen that
Even
either.
I haven't seen
Even I
it.
haven't
True,
seen
so
that.
true. This seems to be very interesting, a gender kind of a thing, and there is no swap of genders, as you said correctly.
Correct.
Madam, my question to you is, you took it up as a single-minded process to, let us say, set up your laboratory, get into clinical practice and get the patients to benefit. You identified areas where you thought being in a position of authority at some point, with, say, the FOGSI when you became its president, and when you went into even ISAR as the president, which was, I remember having participated in the campaign.
It was much
etc.
later in the life.
Yeah,
Yes.
and that is my question to you. You deliberately did not allow these posts to interfere with your academic work, as I may call it, or life's work. How did you manage to, prioritize it? How did you get the timetable, as I would say?
See, or both my involvement with the FOGSI's activity and ISAR activity was much later in the life, when lot of IVF centers had already started coming.
Yes.
And the IVF was being accepted as one of the treatment for infertile patients. So then I had time. Otherwise, there are very few centers in India who were doing IVF. So patients from all over India used to come for doing IVF.
True.
And so there was not much time to spend for the other activities which I wanted to do.
Madam, I remember at that time they used to say in Mumbai, you come to Tata Memorial for cancer treatment and you come to Dr. Desai's clinic, fertility clinic, for infertility treatment.
That I don't know, but then it was very difficult to divert my attention to other things. If I have to divert, that means I have to divert my attention from the patient.
True.
And which was not possible. So when I thought I could spend some time on the other activities, I took up this. First I got involved with the FOGSI and then I got involved with ISAR.
So my follow-up question, madam, is about FOGSI when you took it up. And I remember being part of the campaign and all of us who worked towards the winning of our favorite candidate.
I know everybody worked very hard. I must thank you all for that.
No, madam, it was something which we loved doing and we would love doing it even one more time. The point was that all of us were pretty sure you would take up infertility as your area of interest. But what surprised all of us was your focus that time was on training primary health centers and making them competent to handle emergencies in the absence of things. I mean, I'm amazed just to say that you knew your priorities right when you took up FOGSI's post.
But when I took up FOGSI, I did not take up FOGSI to, make people learn IVF or infertility. Yes. When I took up FOGSI, I decided as a president of Federation of Obstetricians and Gynaecologists of India, our duty is to help government with their problems. Because if as an obstetricians we don't help, then how will government perform anything? And that time maternal mortality was the main thing, which was a government's priority. So what I thought was, if as an association, we could start training doctors working in the primary health centers or community centers and emergency obstetrics, they will not, kill because women used to die before they could be transferred from primary health center to the...
It was a nightmare in our hospitals.
Yes, so that's why we decided that we should do this, and that's why I took up the subject of doing emergency obstetric care for primary health. I did not take up infertility because I didn't think that was government's priority, and
Absolutely.
I thought
at that time
we have to help government in whatever is the problem, because if as a gynecologist we don't help government, then how will government perform anything?
During our training period, when we were undergraduates and postgraduates, when we went for our rural postings, we realized that the real heroes or the real heroic work was being done at the PHC level.
Correct.
Where you had to just make use of the basic amenities which were there.
No resources.
And,
correct. It was so bad.
Yes,
and they were not taught. See, what used to happen was that in the primary health center, the doctors, MBBS doctors would be male doctors who would have not learned any obstetric and gynecology. Exactly. As I know, when I was at St. George's Hospital, all men were, all boys were not interested in obstetric gynecology. Yes. They just used to come to pass exam.
True.
It was the ladies who used to take up obstetrics and gynecology.
Yes.
So they had forgotten their theory also. They did not know how to do cesarean. They forget cesarean. They didn't know even how to diagnose postpartum hemorrhage, how to treat it, nothing.
All correctable things could be preventing deaths and morbidity, which came.
So that I thought, okay, now it is time. If they are taken up the job, let's train them in doing it.
Yes.
As a matter of fact, madam, I remember the mortality rates in cities or big hospitals, as opposed to just about 70-80 kilometers out of the city limits, used to be dramatically different. Correct. And it was quite sad.
But now things are better.
Yes, thanks to the initiatives that have been taken up, and thanks to thoughts and thought leaders like you who contributed to making such a big difference.
Somebody has to make a beginning.
Yes, madam.
Yes.
Then it starts because the idea keeps on rolling. I started IVF and I showed all the juniors that you don't require a very
Fancy.
fancy laboratory or animal
Yes,
house.
yes.
And by the time the culture medium, commercial medias were available, so
Had
animal
started
house
coming.
was not used now anywhere.
Right.
So but initially it was necessary, but then I showed it is not very necessary. So I think it gave a lot of courage because in the government hospital IVF was not being practiced at all.
Yes, absolutely.
So all only clinicians in
Even
private
today,
practice
for
were
that
doing it.
matter.
So they all got the courage to do it. So they used to come to take training. So I was kept really very busy,
Looking at the way IVF is done, where we import most of the medications, the disposables, and everything else that is required, the cost of treatment remains out of reach for many of the middle class or lower middle class families or couples. And obviously, you had come across so many such couples during your practice, and hence you came up with the initiative of setting up the ISAR Sadhana Desai Endowment Fund to help poor couples. And it was the first such fund which has been set up in the country. And also the embryology training course that you started during your presidency of ISAR. These are two
Areas
benchmarks or two areas that
nobody seems to have
has set
matched.
your tenure apart completely as compared to the other clinicians. Please let us know more about it.
See, I'll tell you what. Today, a lot of people do charity for medical aid, but for cancer,
Yes.
for they do it for some surgeries, for heart problem.
Yes.
Everybody does it. There is a lot of charitable trusts are there
True,
which are helping, but nobody is doing charity for patients wanting to have a baby.
Baby. Yes.
So where there is a problem, and infertility is still a taboo in India.
Yes,
Yes,
madam,
it's
it's
a
a
big
social
And it is
problem.
very, very big
It's a
problem.
huge social problem.
So what I thought that if I've got name and fame from the IVF and the patients who are poor who cannot get this facility, so there should be some charity for them. So whatever I get name from them, I must give back. It is the way of giving back to them. So I said, I'll do something. So at least few patients can be helped. It was nothing. It is hardly, whatever I have given is hardly anything. Is India is so vast, we cannot help everybody. But if I thought I'll make a beginning, somebody else in the future will think of doing some charity for infertility patients.
Madam, I must say that nobility, the word, and they call our profession noble. And I know you don't like to be praised often, but believe you me when I say that nobility has to come from within. And I'm sure there's a role of the parents, the teaching. You apparently, your parents in particular, were influenced by Gandhiji's thoughts, and there was a lot of other influences. But taking society as a part of you and you as a part of society is something that I find rarely present now.
No, it is not like that. But we don't, things are more commercial nowadays, so we don't notice it. But I'm sure there are a lot of charities being done. But they may be doing charity in different ways, which may not affect us, so we don't know about it. That is, as far as the embryology course is concerned, what I found when I was the president of ISAR, that so many IVF centers had set up in India, by the time I became president. And there were hardly any embryologists. So it was a problem. One embryologist would go for 1 hour in one center, then would fly to go to another center, then third center. So there was no proper justice done to the patients because they would just come, do the fertilize and go away.
Exactly.
There was laboratory control was not there. Culture conditions were not being maintained. So I thought if we can train our own embryologist, so that at least the centers won't, IVF centers won't suffer. That's why I started an IVF training course from ISAR.
I would like to draw your attention to another small thing, madam. During the course of our infertility IVF field, most people in medicine say that, in the other fields of medicine, changes which are substantial happen at the end of a decade. So it takes 10 years for things which have got established to move out and become something else. So approximately a decade is required for new thought processes to come in. Now, in the 2 decades and 3 decades now, we have gone from having recombinant medication, we have seen the agonist protocol. Then we thought of the problem and we immediately had a solution with the antagonist. And today we are almost at a point where we are talking of zero OHSS clinics, which I'm sure everybody aspires to. Madam, I want you to look at this field, the infertility field, the IVF, and these changes. You've seen them happening under your watch.
Yes, I'm very fortunate that I have been able to see IVF developing from the scratch to this height. The point is this, that medical technology is developing very fast. Let's be very honest. When we were students, things, way we do hysterectomy would remain the same for years together.
Yes, exactly.
But now the technology has changed, and from doing regular hysterectomy, we have come to the laparoscopic hysterectomy,
Yes.
robotic surgery.
Yes.
So nowadays, technology is developing very fast. The same thing has happened in IVF.
Yes.
The technology has developed very fast. If you are not in touch with the subject, in 5 years, the concept changes.
Like
So
we have AI also, which is coming
correct.
to our field.
So a lot of things are changing. So therefore, initially, when I came back from England, that time for gonadotropins were prepared from pituitary gland of the dead patients.
Which is
That
unheard of.
when it gave rise to that mad monkey syndrome,
Exactly.
Yes.
it stopped,
That's
because
when
then
it
they found problems. So then they started taking urine of the nuns and start preparing HMG.
To
So
imagine such a thing happening.
So now see how the development has taken place. So now the things are much better. So
Much safer.
Safer. So the technology is changing.
And it has changed towards the better so very rapidly.
Correct. So now the IVF is accepted as one of the treatment for infertile patients.
All over. And as a matter of fact, the millions of children, there must be a huge contribution from your side, madam. I have another question. This AI, etc., which is happening, more machine learning, etc. Don't you think, madam, there's a role for us as clinicians to be empathetic towards our
I
patient?
think we
to
are one
counsel?
generation behind.
Madam, does
Artificial intelligence is coming in big way everywhere.
Can a
And
couple
so it is bound to come to in IVF also. So artificial intelligence is coming in deciding what dose of gonadotropin you can give to the patient. You have to just say, Alexa, what dose I give to this patient? And then you feed the data and the answer comes.
Imagine a couple sitting there, the wife crying, and you tell them, go to ChatGPT and write your complaint and see how many different forms of letters come.
This is life. You have to. I cannot say there is no place. There is a place for artificial intelligence. People who are very clever will teach others, not by taking lectures, but by creating the ways of telling. So you have to just ask them and the answer comes. There are good points, there are bad points. Yes. The pendulum keeps on swinging from good to the better side.
Yeah.
And sometimes we may overcorrect, so it may come back to its correct.
Me that while I'm ready, prepared to put in the embryos, she says that I have got 2 embryos, but both of them look not the same type. I said, you can see all that. And then she tells me, I think the one which is progressing fast is the better one, but I'll take the second one because I don't want to take a chance. Now, these are instinctive decisions. And I think you grow in embryology, you grow as an embryologist as much as you grow as a clinician. You would agree with me?
There is a place of human touch. Everything cannot be exactly a book picture. So there are variations and sometimes decisions have to be taken. But by and large, the technology is starting dictating the doctors.
Is not the way forward.
Well, let's see.
We want to know, madam, from you, there is a whole new generation of people, and sometimes they say there is nobody to handhold us into understanding the responsibility of becoming a doctor. I can tell you that maybe getting into music or some other field is easier. Medicine demands a lot out of you.
Correct.
What would be your message to the generation who wants to take up medicine? This podcast will probably be seen by people who want to take it up. You just, before we had this conversation, everybody wants to become, as they say, a specialist. And I'd like you to elaborate on
Yes.
it.
See, everybody wants to take life easy. Everybody wants to, have some good hobby,
Yes.
want to work fixed hours and not run around. So doctors also feel like that why should they work from morning to evening, only taking care of the patient. So now newer generation, what I find, they don't like to do obstetrics, get up in the middle of the night and run for deliveries. So they all choose either to become an endoscopic surgeons
Yes.
or they want to become an infertility specialist. So this trend is there right now, and this science has developed so fast, so there is a lot to learn. So if they take up, there is nothing wrong. So they can have also a little spare time to do their hobby.
Yes.
So I think it is not a bad idea if they
You are
take up.
still a very busy obstetrician as well in your
But
practice.
I had no chance to develop a good hobby.
No, I did happen
Whatever
to read.
I had learned, what I was interested in dancing. So now I can't do it.
Yes, it was Bharatanatyam,
Bharatanatyam.
right?
So I can't do it. I was interested in sports, table tennis and all. That I can't do it. So that whatever was my activity at this part of my life, I cannot do it. I like to travel. So I travel.
There are so many incidents. I remember, Madam, you have traveled with the two of us. We've seen the world. I want to ask you another question. I know everybody has asked you about the first heartbeat and how it felt. Madam, I have another question. In 2011, that same heartbeat that you had seen for the first time became a doctor, and life seems to have come a full circle. Can you tell us more about that incident?
No, I don't think. Without anybody's permission, I would like to tell.
Oh, yes.
It is the personal life of somebody. But all I can say that my first IVF baby decided to become a pediatric surgeon.
Wow.
So she is a pediatrician and she is an assistant honorary. Maybe now she is associate honorary in one of the medical college. Her mother said, you will now become a doctor.
Wow. So the whole life comes a full circle. And as they say, you must have influenced even at the embryonic level that these are the values of life. And please, you look back.
But I have patients who have come and told me, doctor, you won't remember me, but my mother, you had delivered with IVF. And now I am become an IVF specialist because my mother wanted to be IVF specialist.
Wow.
I have met those patients also, or doctors also who have told me that they have become IVF specialists.
Wow.
And they were born through the IVF.
Yes.
Madam, one more question that comes to mind is, in other medical fields, we stay behind a lot of our Western colleagues. We stay behind, let us say, the Europeans, the Americans. In IVF in particular, thanks to people like you and the group from Kolkata and Bangalore, we were toe to toe with all the supposed Europeans and Americans. So my question to you is, have you noticed during these conferences, there's something called as the European view and the American view and things like that. But at the end of the day, all of us are specialists who want to do well. How do you see this?
So shall I tell you something? We are very good clinicians. We do as good work as they do. And people who are settled abroad want to come here for taking treatment for infertility. But we are not so good in research. Our data analysis and writing research papers, we are lacking. I think the next generation will have to learn to do the research. The research is not being encouraged. The IVF practice is still a private practice. It is not for the professors and associate professors who have time to do research. I think there where our problem is, and sometimes we have to look up to the others in the world for what new research is taking place.
Yes.
That is where our little bit shortcomings are there. We are good clinicians but not very good
at the pace which we are going.
Yes, there are people who do research, but the number of people are very less compared.
That can happen only if the government setups and government hospitals offer these treatments so that research arm can be added to.
So I believe government is now trying to set up IVF departments in
Yes,
many
they are.
hospitals. So let's hope in the future this part will be taken care of.
Madam, even subjects like biostatistics, how to analyze, how to
But
be...
these students nowadays are taught
Oh, yes.
biostatistics.
Oh, yes.
They are compulsory taught. I know about it. They are taught, but they don't get opportunity to write, because in government hospital this infertility care is not done.
True.
We are lacking in areas like having ethics committees, peer
There is
reviewing.
an ethics committee also in all hospitals. There is also biostatistics are being taught to all the postgraduates, but they don't get opportunity so much to collect the data.
Even I think the new generation should listen to Madam and pick up the direction they should put their efforts into, especially the people who will be in positions of power, as they say. Madam, so many years put together, so many deliveries, so many cases. To the general population, if I had you to give a message about infertility treatment for them, so let's say a couple comes to even a failed IVF, what would be your message to them?
I think counseling is very important for IVF patients, because most of the patients come under the impression that if they spend money and they do high-tech treatment, they are going
Exactly.
to become pregnant. And therefore, when the result doesn't come, first question is, my embryo was so good, why I did not become pregnant? So this is what it is. So that counseling of the IVF technology has to be taught to the patients. They should know that only by spending money, everybody doesn't become pregnant. Human fertility is low. And even mother of 2 kids cannot say, okay, next month I'm going to become pregnant for the 3rd time. Because the human embryo is selected very, very closely and very minutely
Fastidiously, yes, the process is
by
very...
the nature before it is allowed to implant.
I wanted to ask you, ma'am, about when it all started initially, it was IVF. So the male factor or the semen report was very important, and you had to have good motile sperm in enough numbers to bring about fertilization and have embryos. But in the 90s, after ICSI came, suddenly people started giving very less value to semen counts and analyzing reports closely. And this is a trend, unfortunately, which has seemed to get established, and it's being followed everywhere.
Not much research is done on male infertility, because a quicker way is found out to fertilize and have a
by
baby
ICSI.
with ICSI procedure. But I think more research is required for male infertility. That is definitely a point everybody should look at it.
And you would say that you should still look at IVF wherever possible.
Yeah, because right now people want result. They don't want the reason.
They are interested in the first hour, not the second hour.
Correct.
I would say.
And things like PGTA. Now that is a new baby or a new
Kid on the blocks.
Kid on the block,
Correct.
which came about, and initially there was a lot of talk that this is going to be the game changer and it will bring about remarkable improvement.
A lot of research is going on for the genetic testing of the embryo. See, all these years we were only looking at morphological appearance of the embryo.
Yes.
And selecting the best embryo by its morphological appearance and its growth pattern. But it is not necessary that a grade A embryo may be genetically normal. It could be aneuploid embryo also. So it is important to know, to reduce time to conception. It is important to select the right embryo which gives result in quicker way, rather than keep on trying again and again one embryo for so many months. So this PGTA was started with the embryo biopsy, and we have found a lot of problems. There are good points as well as there are some problems which can be, a good embryo can be mistaken to be not a good embryo and not discarded.
Looks can be deceptive.
Yeah, so
as they
now
say.
lot of research is done, non-invasive way of finding it out, what is the genetic content, trying to find out physiology of the embryo
from the spent
media. All this research is going on,
Metabolomics.
so maybe it has a good future.
So, madam, my last question to you would be, that today the trend started of freeze all to prevent ovarian hyperstimulation. But incidentally, we discovered that the frozen embryo transfer cycle results were a little higher. So everybody is rushing into freeze all. What is your
but
comment?
it is today it's proven that freeze all is not good for every patient.
Exactly, for hyper-responders.
It is good mainly for hyper-responders and for poor responders where you want to accumulate the embryos and and then select the best out of it. For normal responders, it increases the time to conception, and there are a lot of dropouts.
Yes.
The IVF has its own shortcomings.
Right.
That it takes longer time. Everybody doesn't conceive in the first cycle.
Absolutely.
They have to try a couple of cycles. So we have to find a way out where we should make them pregnant quickly. By freezing the embryo, you are wasting patients 2 to 3 months.
Exactly.
And then you are transferring one embryo, which is not properly selected. Not purposely, but because of the
Lack of
shortcomings of the selection of the embryo. So patients take so long to become pregnant, they drop out.
True. And sometimes they lead a miserable life because they feel that it never happened, or the discouragement, the feeling of
So
being.
I think freezing technology has really helped a lot of patients. Mainly, one of the complications of IVF was ovarian hyperstimulation,
Exactly.
which the freezing technology has really helped. Almost hardly any patients get admitted with the
The
ovarian
agonist trigger and
hyperstimulation.
everything. I remember,
That's very good.
I'm sure you'd grappled with that problem in the early part of your practice. A hyper-responder
Yeah.
was a nightmare for a doctor.
Correct.
Worse than PPH. So, madam, the going forward, we've discussed so many other things. I want you to give a message to the would-be doctors in IVF. Where does the wisdom come in, as they say, after years, and what is the direction probably they will take to see that we get better results? Or is it that we should accept that human pregnancies don't happen as frequently as others? What would be the final message?
No, I think when as the science advances and the courses, now the government is insisting that the doctors must learn IVF before they practice. So the counseling will become part of teaching. Formerly, people were not taught how to counsel, so that they will learn. They will know how to talk to the patients. So they will learn. So as things pass on, patients will be having better services from the doctors. I don't think the things will remain same as it is today. Things will improve as the technology improves and the knowledge improves in the subject. They will have better opportunity,
move forward in the right direction,
and a better success rate will be seen than what it is seen today.
Madam, I am reminded of a saying at this point of time which I read. It's an old African saying. They say that the pygmies on the shoulders of giants see beyond the giants themselves. It's been our pleasure to have giants like you.
Oh, thank you very much. But I don't think
we, the pygmies, can get to see beyond.
I don't think anybody's pygmy and anybody's giant. All of us are struggling and we are sick.
Figuratively speaking, we pygmies have grown thanks to the insights you have provided, and we hope you continue guiding all of us in the future. It has been our pleasure, and the first episode of this podcast, as we call it, where we say the IVF masters, and who better than the numero uno, the person who can give us the direction to go forward. As a token of our love and as a small gift from our side, we hope you would accept a small memento which Sharda and me will hand over to you.
Nice of you.
A small gift which we can get, and madam will have a look at it. And then madam, a small request. If you remember, in the government hospitals, we used to have something called as a muster, which you used to sign and then you were considered in. We have created a IVF book in that form, a Hall of Fame book. I would encourage you to come to that, write down your comments about today's talk which we had. And on behalf of my entire team, which has helped us, and this is happening from Gufic, I would like to thank you for giving us time.
Thank you for inviting me. I very much appreciate.
It's been an absolute privilege and honor, madam. Thanks a lot.
It's been a pleasure meeting you both after a long time, and I've sat and chatted with you for a long time. I'm very happy.
Thank you.
From the Gufic's Hall of Fame, we are very happy to give you a small gift, madam.
Wow.
You're happy, madam.
I
Thank
hope
you.
you liked it.
Beautiful, very beautiful.
It's been a lot of effort for the entire team,
Very
and
nice.
they have thought of this, and they in their wisdom have decided to
Thank you.
make this the kind of
Let me
plaque.
help you, ma'am. Let me help you.
Yes.
So madam, just wanted you to comment on something that Sharda shot, and if you had liked it. Yes madam.
Oh, it's beautiful.
Since we were
Beautiful.
talking about hobbies, and this happens to be one of Kaustubh's hobbies
Beautiful.
that he's really good at.
Madam, I'm not
But
as
this
good
picture
as...
was taken by me.
Yes.
This picture,
So the better
you should
half
put it
you
in
know.
one of the exhibitions.
Oh my God, Sharda.
I just happen to be lucky with this one.
With this I can claim credit, but it's a smaller frame, madam.
Yeah, it's also good.
Thank you. So it means when the two of them work together, you get similar but different photographs. Thank you for
Correct.
liking them, madam, so
Very
much.
beautiful. Very beautiful.
And you were kind enough, ma'am, to give me a lovely foreword. I remember I had come to your clinic with
Long time
Kaustubh
ago.
and requested you for this. And I'm sure whatever copies this book sold
It's
was
very
thanks
beautiful
to your foreword.
Thank you. That's very nice of you to say that.
We actually told those guys, put that on the front, madam, the foreword by Dr. Sadhana Desai, and he said it sold more copies thanks to that.
It's very nice. It's written here. Very nice. This is very nicely done.
That has been done by the present person who's directing it.
Very nice. 3D effects.
Thank you so much for your encouragement, ma'am.
Very nice.